Interventional radiology fellow here. Just to start off, the reason why I decided to go into interventional radiology is because of the innovative aspect. It's kind of a new budding field. It's relatively young in terms of medical kind of subspecialties, but it definitely has a lot of potential. It's changed all of medicine to a major extent from the early days of every patient being opened up for pretty much every procedure that needed to be done. And now essentially we can treat certain things with needles that previously required full abdominal surgeries. So what is interventional radiology? I see that you guys probably got a reasonable overview from Dr. Norbash. I'm just going to talk a little bit about the summary of IR, its effect on medicine, what it's done to the field. I'm going to go over some more tools that Dr. Norbash had already mentioned, and some additional tools that aren't necessarily using the brain. You don't really want a needle in the brain for the most part. Talk about what can be better. And I'm coming kind of from like millennial generation of, wow, things are a little bit old school in certain avenues. Why is the computer not being used for this type of solution? So, I mean, I'll touch on some of that stuff. And then I'm really interested in emerging technologies, and I'll kind of go over some like what I think are low-hanging fruit in interventional radiology, probably in all of medicine in general. So what is IR? IR is an image-guided, minimally invasive subspecialty. We do surgeries of some sort, very minimally invasive. Usually the patient goes home the same day. We do all kinds of things, and pretty much all of it is based on this one idea, this one Swedish radiologist had back in the 50s, where if you get a needle into a cavity of some sort, whether it's a blood vessel, whether it's a stomach or some hollow organ, you get that needle in there, you can put a wire in that vessel or that structure, and then once you have a wire in there, you can thread different things, different catheters, different tubes, different whatever, and get around the body that way. And it's changed all these subspecialties. Now from interventional radiology, now you have interventional cardiology, you have interventional neuroradiology, which now neurosurgeons are being trained in. They have a subspecialty path that instead of various neurosurgery subspecialties, now a lot of them are choosing to become essentially these minimally invasive surgeons. Endovascular surgery, so vascular surgeons were very threatened by a lot of this development. They used to have to do major abdominal surgeries to fix the aorta. Now you can fix it with two little pokes in the groin. Interventional oncology is a subspecialty of interventional radiology. We can treat tumors directly, finding the blood vessels that feed the tumor and then deliver some beads that are either with radiation or chemotherapy or radiation therapy directly to the tumor. Interventional pulmonology is a new thing in the pulmonology world where they are using image guidance to do minimally invasive procedures. And then interventional nephrology is also another one where they're doing fistula work on patients that get dialysis. So in order to kind of see what's going on in the patient, we have several imaging modalities that we work with. And kind of our bread and butter is fluoroscopy. You guys saw a couple pictures of what fluoroscopic images look like. What's great about fluoroscopy is it's real-time guidance. You can actually see what's going on in real time. There's like a millisecond or two delay between what we do with our wire, our catheter, and actually seeing what's actually happening inside the body. The negative is it's X-ray guidance. We are being irradiated with the patient. Technology is getting better and better, and we're using less and less radiation, but at the end of the day, we're using radiation. So there's always a want to improve that. So, for example, from a fluoroscopic perspective, what you would do is you have this patient on the table. You gain access to one of the arteries, and in this situation, we're going to treat a lesion in the heart, a little narrowing in one of the blood vessels of the heart, and pop it open. So what they would do is they would find that narrowing with the fluoroscopic guidance, get the images, get a wire across the narrowing, and then with a stent, the same stent that Dr. Norbash is talking about, this is another application for those stents, they pop open that stenosis with a little balloon that's mounted, the stent is mounted on a balloon, you pop the balloon open, and it kind of keeps that artery open. Now you prevent heart attacks in this patient. You've essentially converted a procedure that used to require opening the heart up, the whole chest open, look at a beating heart, possibly stop it intermittently in order to fix the blood vessels that bypass this narrowing. Now it's being fixed with a simple stent. This is technically old technology now, but it's still quite revolutionary. Other imaging modality that we use is ultrasound. ultrasound is, I think, as we get better and better at using it and the technology gets better and better, is going to be a very kind of go-to technology for pretty much all clinicians. What's great about ultrasound is you also get this real-time feedback. You are sending these waves into the body, and then these waves are bouncing off the different surfaces, and then you're kind of listening to the echo and generating an image from it. In this instance, we have a kidney that's blocked off, and now the kidney has all this urine that's accumulating inside of it. We're going to drain that urine in order to preserve this patient's kidney function and prevent them from going on dialysis. So the way we're doing it, through the soldier technique, we get the needle in there, we put a wire over that needle inside the collecting system, and then we put a tube and drain the urine out from a tube that sticks out their back. Simple concept, but it's quite revolutionary because these patients would have to have big surgeries before this type of procedure was invented in order to actually drain those kidneys appropriately, or they would just lose their kidney, go on dialysis, and end up down a very terrible path in terms of maintaining venous access and all that stuff. Another imaging modality we're using more and more is CT. CT guidance is also X-rays, and essentially what we do is intermittent CT guidance. We kind of take a picture of a patient. This is a patient who's laying belly down. This is her back. This is her left side. This is her right side. And this is kind of like a cross-sectional view like this. What we're doing here is we're trying to get this needle into this collection here. We know this is a collection based on other imaging that we've already collected on her. And previously, if we wanted to drain this, this is a collection that's infected. In order to drain this, antibiotics alone is not going to cut it. She actually has to have this removed from her body. Before the invention of this type of procedure, she would have to go to the OR, have a big abdominal surgery, a big washout, and then she would be in the hospital for a couple days while the skin's healing from the inside out, essentially, because they can't close the skin when there's a big infection like that. Nowadays, we just put a needle in there, put a wire in that collection, exchange that, put a catheter essentially over the wire, and then drain the pus from the skin for a couple days. She gets better. She can actually go home the next day in a lot of these instances. The limitation here is we're interpreting 3D relationships with 2D images. We're doing these intermittent kind of maneuvers, and you're looking at oftentimes these are really big patients, and you're like guesstimating, okay, this is probably where the collection is. I move my needle, and then lo and behold, if you were to follow this needle path, I'm totally in the wrong direction. This is actually one of my patients. So I had to readjust my needle and put it in the right direction before I kind of did any more invasive maneuvers. So things can be better with this technology. MRI. Intermittent 3D guidance as well. Big limitation with MRI, this is a huge magnet. Big benefit of MRI, MRI gives fantastic soft tissue resolution. So if you were to biopsy a breast mass for a lady who has potential breast cancer, they want a sample of it so they can figure out what chemotherapy she should be on. If you were to try to biopsy that with CT, you're kind of SOL, to be honest. Like, you're not going to be able to see that lesion very well unless you see calcifications, but not all the lesions have calcifications. Sometimes you need MRI. What sucks about MRI is you have a huge magnet, and you can't use half of the different equipment that you want to use. You can't use metal devices in there for certain types of paramagnetic metal devices. It's really slow, it's very uncomfortable, it's loud, and it's expensive because MRIs are money-generating machines, and if you're going to be doing a 2-hour procedure on this patient, as opposed to 6 or 7 brain MRIs on patients with strokes, you're kind of losing out on the revenue stream from the MRI. So MRI guidance is not preferred, but as the technology gets better, as it gets faster, hopefully we'll be using it more and more and kind of being more accurate with our biopsies. So those are the imaging modalities that we kind of usually go to. There's a whole slew of technology that we use in terms of actual devices that are putting inside the patient's bodies. And the most simple one is a needle. Just a simple needle is actually not that simple. Different shapes of the needle give us different benefits. The Chiba needle, this is something that we use if we're just going to poke around in the body for a while, trying to guide us so that we get into the right position. It's very sharp, but it's relatively atraumatic to a lot of the other areas around it. So if you accidentally went through a blood vessel, it's not the worst case scenario. Whereas this is a Francine needle. This is a needle that we would use for sampling a few cells. If you say you have a thyroid gland, we want to sample it, send it to pathology to see if it's a cancer. We can use this type of needle because it shears a lot of these cells off, and you can kind of collect it inside the tube and send it to pathology. Then there's a whole slew of other different needle types, and they all have their different benefits. And a lot of it is just basic physics. What kind of tip should I have on my needle? Biopsy devices. There are a whole slew of biopsy devices. And this is actually probably the least appreciated thing that interventional radiologists have to really get good at, is accurately biopsying different tumors, especially now with personalized medicine. Each tumor has different receptors, different genetic characteristics, and we're going to slowly get really good at treating people-specific tumors with different chemotherapy options. We need to be really good at actually accurately biopsying these lesions and doing it hopefully without causing any complications. So these biopsy devices are very similar to normal needles, except they have a trigger mechanism that kind of, once you position it in the right spot, it shoots over and grabs a piece of tissue. This is an example of what that sliver of tissue is. What's nice about core needle devices is that it actually doesn't just give you cells, it gives you like the architecture that the pathologist can look at and get a better idea what's going on. Ablation devices. This is another thing that interventional radiologists are getting better and better at, essentially treating tumors by freezing them, burning them directly from little pokes in the skin and just parking it in the right spot. The big issue with this is your ablation is only as good as your needle positioning. And today, actually, the reason I was a little bit late is we had the most frustrating attempt at trying to ablate this guy's 2 lung lesions. We have really crappy equipment at the VA, and we were able to accurately place the needles without potentially causing a lot of harm to the patient by burning the skin around the lungs. So we ended up aborting the procedure. But if we had better equipment, if we had better kind of navigational techniques, we could have probably treated this guy's 2 lesions and maybe, I don't know, we won't know 100% whether or not they're cancer or not, and kind of this progression, but potentially if we do enough patients, we could improve the outcomes on these patients with just by frying these lesions without having to put up the chemotherapy. Our wires are actually really complicated nowadays too. So sometimes you want a floppy wire, sometimes you want a stiff wire. Sometimes you want a wire that's really slippery, sometimes you want a wire that reacts exactly on the end that you're spinning it as on the opposite end. So that when I spin it once this way, it rotates the exact amount on the opposite end, so I can maneuver and thread my way through all these tiny vessels. The technology is getting better and better, and steerable wires is a new big thing where I can pull a lever and actually redirect the front of the wire so I can get around 3 different vessels. So there's a lot of room for improvement here. Catheters. This is kind of what we put over the wire so that we can kind of maintain access. And now, back in the day, they just had these one-size catheter. They got bigger over time, they got smaller over time, but now we actually do microcatheters inside these bigger catheters. So we get these catheters into a bigger blood vessel, and then once we have that area secured, we'll put a smaller catheter to the area that we want to treat. For example, in liver cancer, we'll go over a case of that in a bit. Contrast agents are important. Once we're in a blood vessel, we can't see what's going on unless we give contrast of some sort. Usually we use iodine. The problem is a lot of patients have allergies to iodine. We can't use iodine, we use CO2. Body absorbs it really quickly and it doesn't cause any trouble unless you're using it in the brain or in the heart. Most of the time anywhere else that interventional radiologists, aside from neurointerventionalists, are, it's fine. We need better contrast agents, though. Contrast agents that won't cause anaphylaxis on some of these patients and potentially threatening alternatives for patients that do get anaphylaxis. Sometimes we want to destroy the blood vessel that we're in. This is in a patient who has varicose veins. You've probably seen them in an older patient population. They'll have these veins that are actually not working correctly. The valves in them, the veins should be pumping in one direction only, or allowing blood flow to go only centrally. But what happens is the valves don't work anymore, and then the blood flow goes backwards, and they kind of engorge a lot of veins on the superficial, or like the outside part of the skin. So then they get this very ugly looking thing that people don't like. So what we do is we destroy the superficial vein, the big main superficial vein, the sepsis vein from the inside, essentially forces the blood to go deep in the leg. And that's actually done really good for a lot of patients. They like, it's a cosmetic thing. It pays really well. A lot of interventional radiologists like to do venous clinics just for this reason. but it does help a lot of patients. We also use this type of technology, whether it's alcohol foam, lasers, or RFA, in other things that lead into sclerose. There are patients that have malformations, like a big mass in the face, which is a lymphatic malformation or a venous malformation. Trying to treat that surgically could be very devastating to the patient in terms of the scar tissue that they would form. And they actually have found that a lot of these patients, if you try to treat it surgically, it recurs, it actually gets worse. So the way we actually have been treating them nowadays is by sclerosing them slowly over a bunch of visits over time. Put a needle in it and slowly inject a little bit of sclerosing. There is no answer for how much sclerosing you're supposed to give. It's very physician dependent, and there probably could be a better way of doing that, deciding on how much sclerosing should be used, what sclerosing should be used for different lesions. And that's another area that can be significant. Sometimes you want to close a blood vessel off exactly where your catheter is marked. So you can deliver these little coils. This is kind of similar to what Dr. Norbash was talking about. This is that one example that he was talking about where they put a stent over it to kind of occlude that coil and keep it inside of an aneurysm. Sometimes it's a really high flow area, like the splenic artery, where the spleen gets about 20% of blood flow from the heart, or 10 to 20% of blood flow from the heart. And if you put a small coil like this, it's going to fling off into the spleen and cause a necrosis in the spleen. So they've developed these plugs that come sheathed as like a little stick, but then when you open them up, they open up like an umbrella, and they have a very high radial force, so that when you unload it, it pops open and it really grabs nicely onto the wall of the artery. These have been fantastic in use in high flow aneurysms or high flow AV fistulas, different parts of the body where a coil alone could actually cause trouble if it flings off and embolizes distally. Sometimes you want things to embolize distally. Embolize meaning that you release it at the tip of your catheter and you let the blood take it to as far as it can. Back in the day, they used to use PVA. This is something, it's essentially just ground up plastic. That's pretty much what it ended up being. And it was very inconsistent in its effects on patients if you were trying to treat uterine fibroids in women. You can park your catheters inside the uterine arteries, embolize them with PVA, but different women responded differently because the PVA sizes were not very well matched up. So then some smart people came up with the idea of making microspheres or embospheres, these small little shaped beads that are consistent in size, consistent in response, they don't clog up your catheter, and you can actually embed stuff onto it. You can embed chemotherapy onto these beads or other potential things that you want to treat the patient with. Other companies have used resins and glass for this purpose, and the two companies that use these embolics actually embed it with yttrium-90, which is a very destructive radioembolization particle, a radiopharmaceutical. We use this for treatment of liver tumors. So if there's a diffuse liver tumor, you can park your catheter in an area that will kind of embolize towards those tumors. And each of these beads would have a very destructive amount of yttrium-90 on it, and it will fry pretty much all the tumor because the tumors have selectively increased blood supply. So this has actually been very revolutionary in interventional oncology. There's a lot of research that still needs to happen for it, but it's the more research that comes out, the more it's showing that it actually is beneficial. It's increasing survival in patients that previously had untreatable liver cancer. Sometimes we want to throw stuff off into the distance and we want it to be resorbed by the body. We don't want to completely block it off forever. This is when we use something called gel foam. It's pretty much just a gelatin material that the body resorbs over time. This we used actually last night in a patient who had a trauma. He had pelvic fractures. We don't want to this is normally a healthy patient. He got in a car accident, and they have all these fractures down below and they're bleeding into their pelvis. The way we're going to treat them is we're just going to slow that bleeding down so that they can heal naturally. And we use gel foam for that purpose. Similar to what Dr. Norbash talked about, sometimes we want to open these vessels up. You can balloon them open. You just balloon it by itself. Hopefully it stays open. You can put a stent in place. Same general concept. Here's what a treated lesion could look like. Sometimes we want to catch stuff. This is similar to the protection device that Dr. Norbash talked about. And then we also have another protection device called an IVC filter, which you guys may have seen or heard about on TV from all the lawsuits that have been coming out on some of the filters that were not actually beneficial to the patients. It causes a lot of side effects. But there's a major benefit to using IBC filters in some patients. These are filters that you use to catch blood clots coming up from the legs in patients that are high risk of getting pulmonary emboli or blood clots that can make it to the lungs and essentially can kill a patient on the spot. So they have a lot of potential benefit, but in the past they used to just be placed in there and they were expected to be permanent. Now they put little hooks on there and now they're retrievable all of a sudden. So 6 months after you place it, you make sure the patient's anticoagulated, make sure they don't need any more. Now we're trying to pull these out in patients. Sometimes we want to drain stuff. We just want to put something in a place to drain it out, like the pus example that we had earlier. Our go-to catheter type is a little pigtail thing. They used to just place straight tubes in there. Then they found out that those would always fall out of the patient. It's hard to keep a straight tube inside the patient. So then some smart person figured out, well, let's just make it coiled and then put a little string on there to tighten and lock that in place. Simple concept, very effective solution. Pretty much everybody uses these types of catheters nowadays. Sometimes this is something you don't want it to be temporary, you want it to be a little bit more permanent. You can use these Clorox catheters. There's these little white things here which are cuffs on them. Essentially a portion of this catheter is tunneled under the skin in order to minimize infection. These catheters are used in patients who have say lung cancer or breast cancer that's metastasized to the lung, creating a lot of fluid in them. They can just pump out that fluid at home. These are patients who are probably going to be terminal, they're going to die, but you're just improving their quality of life a little bit. It allows them to breathe better by being able to pump the fluid out instead of having to come in once a week to get it done in IR suites or in the clinic. And then there's the big mama of catheter drainage solutions, which is Denver shunt. Some patients develop a lot of fluid in their belly called ascites, and instead of just draining it and taking it outside the body, it has actually protein in it, electrolytes in it, a lot of things that are potentially beneficial to the patient. Instead of just dumping it, let's just try to feed it back into the venous system. Somebody came up with the idea of doing this. There was a major complication with this though. Major complication being DIC, which is diffuse idiopathic coagulopathy, which really what's happening is all the stuff that's inside the ascites that's been sitting there for years, you put it back in the bloodstream and it creates a big coagulation cascade and patients were dying from this. The solution is very simple, just irrigate out the belly after you place it, and then all of a sudden patients were doing well with this. So this is actually very effective in some patients, also another palliative treatment, but it does help the patients that need it. So I was thinking to myself last night when I was making this, what are some clinical needs that, if you guys end up shadowing me, where are the clinical needs? And I kind of was thinking about the morbidities and mortalities that we've run into. With interventional radiology, we're kind of the last ditch effort for a lot of people. They want to come to us to hopefully solve their problems for them. But at the same time, we kind of get into a mess. Sometimes we end up causing trouble ourselves. So there can be things that can be done better. And I think non-diagnostic studies is a very commonly underappreciated thing that we don't excel at. So when people send patients to us to sample their lesions, their liver lesions, their lung lesions, if we sample it, we send them on their way, and we don't get a good sample, they're not going to get the right chemotherapy, they're not going to get the right treatment. That's something that we need to be better at. Inadequate ablation of tumor, same thing. We placed the needle in that area. It was a millimeter off. We chose the wrong needle type. We chose the wrong ablation zone. We didn't do the patient a service. This could have been a very easy solution if we had better decision-making capabilities at the time of the needle placement. Tubes getting pulled out on accident. We had a guy last month who 3 times, he had a tube inside his gallbladder. 3 times it got pulled out in his nursing home facility. Every time it gets pulled out, he gets sick again because the gallbladder is blocked. It's infected. So is there a better way to do this? Can we place like a breakaway catheter of some sort so that if it gets pulled, it doesn't pull out the catheter from inside of his gallbladder? Plus there's the potential of causing the trauma when you're pulling it out. It's going to cause some injuries. I don't want to injure structures that are near my target, but sometimes my target is near very important structures. Sometimes it's right next to the carotid artery. There's a little lymph node. I don't want to injure it. Sometimes I end up injuring the carotid artery. So can I target my stuff better? There's a lot of devices out there, and I don't have enough training in all these devices. And then sometimes that's all, I move to a new hospital, and that's all they have. I don't get adequate training. Is there a better way to train people kind of more robustly with the different devices that are out there? Sometimes there's a lesion or something that I want to treat, but it shouldn't be treated. Maybe it's not actually an abscess. Maybe it's just a little bulging off the urinary bladder. We actually almost ended up getting suckered into putting a drain in somebody's bladder because everybody thought it was an abscess. It wasn't an abscess. It was a tiny little weakening in the wall of the bladder, and it popped out. It shouldn't be drained. Fortunately, we figured out that was the case. But that's something that becomes a problem in a lot of cases. And then another big one is poor patient education. We do all these complicated things on patients, but we don't educate them properly on how to take care of themselves, how to do stuff. We think we do, we give them pamphlets and stuff, but they don't have the education to really appreciate what we're telling them, so they end up going home and end up in trouble in a very preventable way. So, I mean, this is kind of a basic set of things that I think are preventable morbidities and mortalities. We should be really getting good at, almost getting to 100% success rate to prevent all these kinds of things. So what are some low-hanging fruit with emerging technologies that are out there? I like the idea of brain games. There's like luminosity and all these funny things that people talk about. Well, I mean, why don't you just create something like that for physicians, or for nurses, or for patients, so that they can actually keep track of things better, or how to do things better. You can train people with brain games. Machine learning, that's kind of a given. Everybody's talking about it nowadays. It can be useful for medical decision making or computer-aided detection. Augmented reality and virtual reality. This is on the horizon. This is actually one of my major interests. Playing around with the HoloLens, just for figuring out the solutions for image guidance from a clinician's perspective, as opposed to looking at a patient who's a 3D person in 2D. Why don't I just look at the 3D person in 3D? Actually overlay the images on them accurately would be a massive improvement in the way that we're doing things right now. You can also use this for simulation and training, improve visualization, and then a clinician heads-up display. Sometimes I'm scrubbed in. It'd be nice to have all the patient's data, access to the medical record, and all that stuff right here. I can just look over and do some maneuvers and hopefully navigate through it. And then cryptocurrencies. I mean, people laugh about this stuff, but I mean, it's becoming mainstream. It really is, and there's a lot of potential here with the technology, with immutability, with smart contracts. What are some solutions we can find in medicine? I think this is a really hard problem to solve because it's such a new technology, but I think it's worth thinking about in the back of your mind. What solutions can we provide with this type of technology? So just to go over some basic stuff I did with augmented reality, very basic. This is all my free time as a radiology resident. So the current state of ultrasound guided procedures is you have a probe, you have a needle, you have a patient, which are monitors over here. So I'm supposed to be able to put my probe on the patient, line up my needle correctly, make sure that everything's in the right spot, and then look over here and do this. It's kind of silly when you think about it. Why isn't everything in the same field of view? You try to do it, but sometimes it's really hard. Sometimes it's a paraplegic patient who's in a very awkward position, and you just can't place the monitor in the right position to do that. You're kind of doing this weird thing, your hand is shaking, and you're like poking around hoping that you end up in the right spot. Very basic option. We have Google Glass device. We just did image capture from our ultrasound machine and streamed it to Google Glass. It worked really well. Google Glass at the time was very limited. We couldn't get good latency. We were about 150 to 200 millisecond latency on that, but it worked well enough. I could get access into a cadaver, and the potential just showed that this could drastically improve at least new people's ability to do ultrasound guided procedures, or the basic clinician who does a very basic thyroid biopsy or a basic line placement on the floor. It just makes their lives a little bit easier, and they're going to be more accurate that way. AR and VR simulation center. So this is actually a video game. It's a really funny video game on the Vive. You can play surgeon, but you kind of do a lot of messed up things to the patients on it. But essentially, the idea is kind of cool. Like, you can put yourself in an environment in trauma-based situation where now you can have your first-year resident who's never been in a crazy, chaotic situation where a patient comes in after a car accident, and you can kind of place them in that environment, let them experience what it's like see the different roles of the different clinicians in there so that when they're actually there, they know what their role is going to be a little bit better. You can introduce them to equipment this way. You can simulate treatment scenarios, and you can allow the trainees to experience all the roles of the healthcare scenario. So instead of just putting them in the position that they're supposed to be in, what if you put them in the position of the nurse? So they have an idea of this is what the nurse is doing. What if you put the nurse's position as the scribe? So she has an idea what the scribe is doing. So now you can kind of really simulate an environment much more beautifully, I think. There's a lot of work going into this. I think there's a huge benefit, and I mean, there's so much room for improvement in just simulation. The current state of CT-guided intervention, this is what we were talking about earlier. You're looking at these 2D images over here. This is going from the head to the feet. There's these 4 images, and then I place my needle here. I know I'm in the right plane, so I just have to adjust my needle this way. But it's kind of silly that we have to do it this way. There could be such a better way to do this. Oh shoot, this is an older one. Essentially what we had done was we just took a phantom, which is a kind of a model. We scanned it with a CT scanner and created a 3D model of it and just overlaid it on the phantom and looked at it with the HoloLens. Simple concept. It's manually co-registered, which is kind of BS, to be honest with you. But the idea is pretty strong. Being able to actually take a CT scan, reconstruct it in 3D, and overlay it on a patient would be revolutionary, I think, to the types of procedures that we're doing. I'll tell you, if we had this option for the guy that we tried to do earlier today, we would have, I think, been successful at least with one of the lesions. The other one was really difficult, but it would have probably had fun. So there's other social benefits to IR in terms of kind of building up this minimally invasive type of procedures. IR has potential to lower healthcare costs significantly. The less time taken stuff in the hospital, the better it is for society in general. And another quick example of this is in Europe, where they're able to do a lot more studies than we are here in the States. They were able to get these patients that have these, this is kind of the pelvic bone here that sits right above where the femur is. So it kind of holds the femur in place. It's the cup of the ball. Sometimes this fractures in patients that get in car accidents because when they're like against the dashboard, the femur pushes up and it creates an acetabular root fracture. It's a very classic thing. The surgical solution for this is cut down, put a bunch of screws in place, and keep everything together. They get stuck in the hospital for about a week, 2 weeks. Hopefully, don't end up with lower extremity DVTs and pulmonary emboli. Hopefully, they don't get infected. Hopefully, they don't get pneumonia. And then they hopefully end up recovering from sitting still for 2 weeks straight. Instead, these guys took the CT scan of these simple fractures and were able to actually percutaneously, through the skin, deliver these little screws and rods to kind of keep that in place, just through a needle poke. It's a simple concept. This should be like standard for a lot of procedures that we do nowadays, but in 2013, this came out and it was revolutionary in the orthopedic world, that they could actually do a percutaneous fixation of an acetabular root fracture. These patients went home the same day. These patients came into the ER after the motor vehicle collision. They didn't spend time in the hospital. They went home the same day. They got their follow-up with the orthopedic surgeons, but overall, they didn't have to worry about the complications of being in a hospital, and they got to maintain their livelihoods on a daily basis. So overall, just a set of examples of what you can do with minimally invasive procedures. We can hopefully decrease the waste and increase efficiency in medicine, which is absolutely necessary. I hope that you guys help us out with that. I would kind of want to be in your position to some degree, but it's kind of hard with the amount of time that you're left at the end of the day. And the key takeaways I wanted you guys to have is IR does a variety of procedures, which requires imaging, often in a less invasive manner. And then why innovate IR? So inherently, IR is an innovative subspecialty, and this is a good field for you guys to kind of grasp onto, because as interventional radiologists, we like trying new things. So you're more likely to find practitioners that want to try new things. We tend to treat the sickest patients that can't undergo surgery, so we can't really make them worse off for the most part. We try to do a good job of making sure we don't do that, but for the most part, we're kind of salvage options for them. So we get the options of trying new things in an ethically safe way. We do a lot of minimally invasive options which are cheaper and more likely to be adopted. As this gets better and better over time, more patients are going to get more minimally invasive procedures. IR has a wide tool set. There's a lot of things that can be improved, from the needles to the biopsy devices to the guidance to different imaging modalities that we use. And there's a whole lot of unmet clinical needs every day that I'm working on, like, man, this could be better, this could be better, this could be better. So, I mean, I'm sure when you guys kind of rotate around and start watching clinicians work, think about that. A lot of clinicians don't want to think about that because it's kind of, to them, it's a challenge that they want to be good at. So if you realize that they're kind of taking it offensively or defensively, that you're asking, oh, why, how can this be better? Feel free to ask somebody else. don't pressure them too hard, because some of them take it a little bit personally that they're being asked by people why the outcome didn't turn out as well as it could have been. But it's something to keep in mind. There's a lot of things that can be done better.